Now the blinatumomab is approved for pH-positive ALL. It's certainly a consideration as well. There are only now the very inkling of data to suggest that maybe we can combine TKIs with blinatumomab. I'm not sure I'm quite there yet. People around the table may disagree with me there. But similar to the story in pH-negative ALL, generally in my experience, blinatumomab works really well for people with low burden disease, and it doesn't work particularly well in people with high burden disease. So I might try TKI plus minus chemo to try to get a little bit of disease control, then maybe come in on the back end with the blinatumomab. Again, if they're a transplant candidate, using it as a bridge. If they're not, maybe just trying to string things along for as long as I can.
I think the studies that have been done have borne out your experience that
Yes.
the response rate is higher in patients with, I mean, they used a cutoff of 50% blast. So if you have less than 50%, there's more, you have a greater likelihood you're going to respond to the blinatumomab.
I want to extend that though, and I want to extend that concept to extramedullary relapse, because we do see that more common in the relapse refractory space, where they may have large nodal deposits or even just other extramedullary sites of involvement. I've had very limited success with blinatumomab in that setting, and that again may be a situation where I'll, during the sort of 2-week break, I'll integrate something like a Marquibo, or in the case of pH-positive ALL, if they weren't getting it concurrently with the TKI, integrate the TKI.
Yeah, and there was recently a publication that speaks to the lack of strong activity of Blin in the setting of extramedullary disease, and it's likely an immune microenvironment issue, but definitely I've had patients as well with extramedullary disease that had responses in their peripheral blood and their marrow, but that tumor mass in the retroperitoneum or wherever it was, it's still hot on the PET scan when you look again, and that's particularly problematic. So that might be a scenario where inotuzumab might be favorable because, and again, we don't have a lot of data for extramedullary disease on inotuzumab. All of us are going to learn this through our clinical experience, but certainly I'm compelled to try it for those patients with extramedullary disease.
But there it makes sense also to maybe cytoreduce the patient to reduce the extramedullary disease, and you can either use inotuzumab with chemotherapy or chemotherapy alone, and then once that's been reduced, then you can come in with the Blin.
Mm-hmm. And then transplant them.
Exactly. The challenge for me with the cytoreduction, as we step up the intensity, we really do run into a lot of problems with infection, at least at our site, and that has been somewhat dose limiting, which is why for us, I'm trying to figure out, Marquibo kind of combinations, right? So how do I de-intensify things just to help control that extramedullary relapse, and then very quickly follow with blinatumomab?
I mean, often you can just use a CVP-like regimen.
It's possible. I mean, it's, what I would
love...
love...
Marquibo, any of those agents.
Yeah, I think what we see is that with chemotherapy, the response rates are about 20%. And that was actually the CR rate for Marquibo that got it approved. So the answer at the end of the day is going to be, how do we combine these things to achieve the best response in the relapsed refractory patient? I think Marquibo is great because it's well tolerated, but you've definitely got to add something to it if you want to have a good response in the majority of patients.
Well, again, and this is just to manage the extramedullary disease, and kind of what I tell my patients, poke holes in the tumor and the masses so that the blinatumomab can do what it needs to do.
Yeah.
I mean, another option which hasn't been done is when you use blinatumomab for large cell lymphoma, the dose of blinatumomab is much higher, where you get better and it's given for a longer duration. So that study.
If your med center allows you, because it's very, very expensive.
I can't do it. Exactly.
That's correct. So maybe eventually, I don't know if it'll ever be done, would be for patients with extramedullary disease to manage those patients like you manage lymphoma patients.
Exactly. The challenge, of course, will be the CNS events that develop as we bump up the dose. I do think we have to be cognizant that as we push to 104 micrograms, that we really are going to see more CNS toxicity. I think they saw seizures as the limiting grade 3 toxicity on the phase 1 studies.
I think just to maybe round out the discussion, to not leave out our unfortunate patients with T-cell ALL, where the options have not been quite as evolving over the last few years. Really, nelarabine and liposomal vincristine, at least to my knowledge, are the two drugs that are sort of uniquely approved in that situation. My experience with nelarabine has been hit or miss, to say the least. I've seen some patients develop pretty significant neurologic toxicity from it. But I've also seen some really impressive results, but again, it's mostly anecdotes. And again, that is not a therapy that I would think is a standalone, really is a bridge to transplant if we can get them into remission.
Right. So for the very high-risk TALLs, I haven't seen much activity at all with nelarabine. I've been really pushing a lot of asparaginase. We're a high-perCVAD center, so most of these patients didn't get it with their induction. But even in some who started with a COG regimen, so some of the young adults who make their way from our children's hospital down the road, I try to use an asparaginase intense regimen like a VXLD backbone. I like the Velcade VXLD. I've gotten some good responses with that. It's toxic. I don't want to mince words. It certainly neuropathy is no small matter with the regimen, but hopefully with I think the tackle group is now working on a revised regimen using Kyprolis in place of the Velcade, and we may see some very interesting data emerge from that ongoing study. I think venetoclax is showing some interesting responses, at least preclinically, in the early T-cell space. So hopefully that's an agent that moves forward. Certainly it's moved forward for a lot of other indications.